Hello guys, my name is Maxim Belograd, and actually we decided to do this webinar, which is free of charge for you, after our discussion with Pascal Manier about IDS. We discussed this high topic on demand with Master, and many of you asked us to do some highlights and to make some clarification about clinical steps, about some procedures that you can use in your daily basis. So we are doing this video after our really nice discussion with Master. Basically, I would like to start with his article, which was published in 2005. You see that the concept of immediate dentin sealing is pretty old. It's not something brand new, but still, despite the fact that the concept was introduced more than 15 years ago, people are still thinking about benefits and advantages that they may have from utilization of the concept, and actually how to do this concept in proper way in our daily routine. So today we will do discussion and we will share with you steps about immediate dentin sealing, which include problems discussion. We will discuss with you benefits of the IDS. We will also discuss with you clinical protocols by utilization of total edge adhesive systems and self-edge adhesive systems during tooth preparation. We will be talking about impression taking also, provisional restorations, some nuances and tips and tricks with that topic. And for sure, I will tell you in details how do we prepare teeth with IDS for adhesive cementation of our indirect restorations. So our discussion and our interview with Master, with Pascal Manier, we started with questions, and we raised up problems that we as practitioners, as practical dentists, have in our daily basis with indirect restorations when we are working on vital teeth. So for example, one of the main problems that we may face is postoperative sensitivity. Personally, before I started to utilize immediate dentin sealing protocols, I had pretty many cases with post-op sensitivity, and I was suffering treating my patients with veneers or crowns or overlays on vital teeth because of that problematic component. Also, we can have all problems like debonding, especially when we shifted into the minimally invasive dentistry, when we shifted into adhesive dentistry and started to do more and more non-retentive preparations like veneers, like tabletops, like occlusal veneers, like overlays with non-retentive shapes of our preparations. And also what kind of problems we still have is what type of restoration to do in certain cases. Before preparing for the interview, I decided to do some questionnaire on my Instagram page, and I asked colleagues, I asked you to give your opinions regarding restorative selection in certain clinical cases. Like for example, if you have case with moderate dentin exposure, which means less than 50%, would you will go for crown or veneer? Okay. Then I asked also about cases when you have severe dentin exposure, but the margin of your preparation is still in enamel. Would you go for veneer or for the crown? And the last question was about extreme dentin exposure and margins with no enamel. Okay, and let us see results of these questions and answers. So, in case when you have moderate dentin exposure, more of our colleagues voted for veneer. It's about 83%. Then, in case of severe dentin exposure and margins in enamel, we have 58%. And you know, when you have no enamel on the margins and extreme dentin exposure, more people voted for crown. So all these problems that were mentioned, like postoperative sensitivity, debonding, and restorative type selection, I asked to Pascal Manier, and let me share his answer about the last question.
Crown or overlay?
Maxim, excuse me, I don't understand. What's a crown?
I don't know this restoration.
So basically, with that answer, he clarified that in cases where you have a lot of dentin exposure, even in case where there are no margins in enamel, you still can do minimally invasive ceramic or composite or hybrid restoration. If you will use IDS, you will get sort of benefits in terms of less postoperative sensitivity, or almost zero, let's say, and better bonding strength. I would like also to share with you some interesting quotes and thoughts of Pascal Manier, which were really nice and funny, and then we will continue with explanation for that topic that we are discussing right now. So IDS is like your seatbelt. Let us listen.
And you know what, Maxime? I remember what you just said. When you put your seat belt, you know, it takes a few seconds to put the seat belt, right? So IDS is that. It's your seat belt, okay? Invest in the seat belt, please.
It was actually a good point, because we discussed with Pascal Manier that if you will do IDS in proper way, following all the steps, all procedures, it is time consuming. And then he said, just imagine the case when you put a lot of restorations, when you made a lot of restorations, indirect, expensive restorations for your patient, and then your patient suffers from postoperative sensitivity, and you have to, in some cases, you have to replace these restorations. How much time and how much money will you lose in that time, in this case? So basically, if you will invest in IDS, you may not lose your time and money later on because of the postoperative sensitivity and because of the better bonding strength. So that is really interesting thought that gives you some confidence regarding utilization of that technique. We will discuss with you benefits of that technique a little bit later on. Okay, and another interesting quote from Pascal Manier is that it is sad when you lose the pulp because you messed up the bond.
It's very sad when you lose a pulp because you messed up the bond. That's a disaster.
It's true, because he shared his experience, and he shared experience of his students and colleagues who suffered with these postoperative sensitivities, and some people they had to do endodontic treatments for teeth with that severe postoperative sensitivity. But the problem was not about restoration selection or because of preparations or whatever. It's because of dentin that was not sealed. So let us just briefly discuss benefits of the technique as IDS, immediate dentin sealing. So first, it blocks sensitivity during provisionalization, and also you will get almost zero postoperative sensitivity after final cementation. This is actually clinical benefit that you can see, that you can feel, because there are many scientific benefits, some things actually that we cannot see, but we may understand them from the research, from the data that we have scientifically based or whatever. But actually, if you have postoperative sensitivity and then you start to utilize IDS and there is no postoperative sensitivity, you can see that, you can feel that. IDS brings comfort. What does that mean? Just for example, when you do a big case, a lot of teeth to be prepped, like a full mouth rehab, and all teeth are vital, and you do preparations, and you expose dentin, and just imagine you made an anesthesia on one side, and then you prep this one side, then you continue preparing it on the another side. These sides start to be sensitive. You have to do another anesthesia. So it's a little bit, it's a messed up with all these steps and procedures. And then you will have to take an impression. You have to put retraction cords everywhere. You have to dry. All teeth are sensitive. You have to do a lot of anesthesia. So actually it's a headache, to be honest, to do that type of big cases on vital teeth when you have a lot of dentin exposure. Another thing is when you have your patient for try-in of the final restorations, in case when there is there is dentin exposed. So what you can do, you just take out your provisionals. Dentin is sealed in proper way. You can do try-in of your final restorations, and it is much more comfortable for you and for your patient during try-in procedures. IDS protects dentin against bacterial leakage. All our provisional restorations, they are not perfectly seated. They are not perfectly fitted, and they are not hermetic enough to protect against bacteria. If dentin is sealed, we are safe. Then it is proved that freshly cut dentin is ideal substrate for dentin bonding. And when we do preparation, when we expose dentin, that means that dentin is fresh right now. So it's a good way to do immediate dentin sealing right now to get better bonding strength. Also, pre-curing of the bonding agent leads to improved bonding strength. It is also proved, and you know, when you do indirect restorations, which have to be precise, okay? In this case, when we cement these indirect restorations, we do not light cure bonding agent on the tooth or on the restoration, because the frame of bonding agent may let not your final restoration to sit well, okay? So the fit of the restoration will be compromised if you will light cure adhesive. Another thing why we have not to light cure, okay, let's do another thing. You may say that, okay, but if we will use non-filled adhesive, which is thin, we will dry it, okay, it will be really super thin, then we'll light cure and nothing will happen. In this case, you are right, but if you will have thin adhesive layer, very thin, which is thinner than 40 microns, okay, or 50 microns, that number that I picked up from the interview also, this adhesive can be inhibited with oxygen completely, and it is not good for bonding strength. Thick hybrid layer works better in adhesive dentistry, really. So another thing that may happen, if you will decide to make it thin or thick, let's say, and not light cured, and your dentin is not sealed, which means there is no hybrid layer in dentin yet, okay? So you have non-light cure adhesive, then you have your cement, you bring it together, then you light cure together, and every single light curable materials that we are using for cementation, doesn't matter, cement or composite or whatever, they shrink. And it may debond, or due to shrinkage of composite, due to shrinkage of your cement, these non-polymerized adhesive may be detached from the dentin, and you will get postoperative sensitivity afterwards. It may happen, it may not happen, but in most of the cases it may happen. So basically this is another clinical problem that we may face with. Okay, and immediate dentin sealing allows stress-free dentin bond development, which is good. Nothing is acting on our hybrid layer, nothing shrinks over. So basically it's better than the situation that I tried to explain to you before. Okay, let's go to the clinical protocol. Okay, that is important. Now I will give you all the steps of clinical protocol, detailed. And what is super important in that procedure is that you have to follow all the steps and all the tips and all nuances, because if you will skip any of this step, your final result may be not good as you expect. So I will do it first for total edge adhesive systems. Okay, we do our preparation, then we expose dentin, then we go with our IDS procedure, which is basically a regular bonding protocol in dentin. In case when you do IDS, no need to prepare enamel, with adhesive, but just to be safe, just a peripheral area of enamel can be involved into the process. So basically, you will etch this area of enamel, really peripheral area of enamel. No need to etch all enamel that is exposed. We have to keep it virgin for final cementation. So we just do a peripheral etching of enamel for, let's say, 30 seconds. Then we etch dentin for 5-15 seconds, okay? And then we rinse and then we dry. But when I was explaining, or when I was telling this to Pascal Manier, he was listening, he was examining me actually. He said that I missed one thing. Let us see.
Maxim, there's one before.
One thing that
I agree so far, but there's one more step. There's one more step. You already missed one step.
Exactly, roughening, right?
Roughening the dentin.
And
that is freshly cut dentin.
Rubbing isolation.
Yeah, see, a lot of small things that we have to take into consideration. Roughening of the dentin, this is important. So basically you finish your prep, your dentin is exposed, it's good to make it rough for total edge systems, because we are discussing now total edge systems. So how to make it rough? You take diamond, coarse diamond, low speed, and you make the dentin rough. So it will be wavy, and it's better for bonding to the dentin in such way when you use total edge system. So by the way, I forgot also one thing that is also important, rubber dam isolation. So first, rubber dam isolation, let's say. In this case, people start to hate me, the ones that are not using rubber dam, but honestly, if you can control super nicely, completely wet environment, you can do IDS in vestibular areas of frontal teeth without rubber dam. But personally, I prefer rubber dam isolation. So this is a step number one that I follow all the time. So rubber dam, then you make dentin rough, okay, with a coarse diamond. Then you etch peripheral enamel for 30 seconds. Then you etch dentin for 15 seconds. If dentin is sclerotic, you can extend process of etching for 20 seconds. Okay, then you rinse, and then you dry. In this case, you have to be really careful in terms of drying, because the total edge adhesive systems, they are very sensitive to so-called wet bonding, because if you will dry it too much, the bonding strength will be decreased. If it will be too much wet, the bonding strength will be decreased. So the way we dry is when you actually, I take my suction without cover, and they just with a suction will suck down the water from the tooth. If we work with on posterior teeth, from the lingual side, let's say we keep suction, and triplex with air spray we keep perpendicular to the suction and parallel to the occlusal surface, and then we dry. In this case, enamel will be dry and dentin will be wet. And there was a really good tip from Pascal Manier, is that how wet is wet, actually, the question. And he said that the dentin is shiny, you cannot see liquid movement, but you can see roughening on the dentin still. In that case, it's good substrate to apply your primer. I'm giving you protocol to use bonding agent, classic one, 4th generation, when you have separate primer and when you have separate adhesive. So after you dry, you apply primer. Primer has to be applied in active way with a micro brush or with a regular brush for 20 seconds. Okay, Pascal personally prefers to put several layers of primer. He said 2 or 3 even. So one tip, if you will do this with micro brush or with a regular brush, don't touch enamel with a plastic base of the brush, because it may break enamel prisms that are already etched. So you have to be careful with enamel in this case. And then you apply this primer 20 seconds, then you dry. Okay, and again, in this case, you dry it until the dentin becomes shiny. There is no movements of the liquid, which was primer, and you still have to see that roughening. In this case, it's good to work with magnification. Okay, magnification, as Master said. So then you apply adhesive. Okay, the second bottle. Actually, he works with Optibond FL Me Too. It's highly filled adhesive, which performs a really nice hybrid layer. So we put our adhesive to the dentin, and it has to be thick. Basically, it has to be about 80 microns. Okay, so we put it, we don't dry it. You can just take out excess with some suction, for example, or with a dry micro brush, or with a dry brush, but you have to keep it thick. And the good thing from Optimum FL is that adhesive is filled, and it creates uniform layer of itself, let's say. And then we light cure it. We light cure it for 20 seconds, then we cover it with glycerin gel, and we light cure it for 10 seconds more, just to light cure oxygen inhibited layer. Okay? In this case, I would like to give you some tips regarding that protocol. First, if you are using, for example, non-Optimum FL, another adhesive that you are using, in this case, you have to create pretty thick hybrid layer, and most of adhesives, they are thin. So basically, you apply in that way your adhesive, you light cure it, and then you can reinforce this hybrid layer with a thin layer of flowable composite. Okay, so you add some flow and then you light cure, and then you're done. Another thing that is also important, it's easy to do IDS in case when you have cavity, carious cavity, especially when you work on posterior teeth. But if you work on anterior teeth and you prep anterior teeth for veneers, for example, for the crowns, and the surface is plane or the surface is convex and you have dentin exposed, in this case there is a tip that before doing IDS, you have to create a little bit more space in dentin area. So basically you go for step 1 of preparation, which is rough preparation, then you go for the step 2, which is detailed preparation, then you create slightly more space for your IDS. So basically I take rough burr, just cut it a little bit dentin again more, and then I go with IDS, okay, and then I go for step 3 of preparation, which is let's say finishing of our preps. I use discs or rubbers and red diamond burrs in a low speed just to remove adhesive from enamel and to decontaminate my finish lines if the finish lines are in enamel. So in this case I do step 3 after IDS just to clean my preps, my enamel areas from the adhesive or from flowable composite. Okay. Another thing which was also interesting is that if you have margins in dentin, okay, there is no enamel, there is margin in dentin. In this case, you have to add like 2 microns more of your preparation, so you actually create some slight, like a lip or whatever, just a little bit more preparation on the margin, and then you add adhesive, and it flows down and covers this exposed dentin with enough thickness. So that is the tip, okay? I would like to say also, guys, that we decided to include clinical parts of IDS, clinical demonstration of IDS to our new online masterclass about veneers and discoloration, or veneers and color change. We have this masterclass. You can join this masterclass using link to the description of this video. Below this video there is a link, so you click there and you can have the program of our masterclass. It's really tons of information, a lot of information about planning, about ceramic systems, about communication with dental technician, preparation designs step by step, then IDS and mock-up and whatever. So you'll have a lot of info, and we'll demonstrate IDS there completely step by step. Okay, now let's go to discuss the IDS if you do it with self-etch adhesive system. Let us listen to the master.
So if you use a self-etching agent,
Okay.
actually there is 2 ways. I would say there is the productive way, and then there is the maniac way. The maniac.
Maniac way. So what does that mean? If you follow the basic protocol, you do selective etch of enamel. In this case, you have to be super careful in order not to etch dentin, because your self-etch adhesive system will not work then. Okay. What is also important, if you use self-etch adhesive system, you have to prepare your dentin in a specific way. In this case, the good thing is to have carbide burr. Okay, so you just make dentin preparations with carbide burr. Carbide burr does not create thick smear layer, because if the smear layer will be thick, your self-etch adhesive system will not work efficiently indenting, so carbide burr, okay? And then you go selective etching of the enamel, okay, rinsing, drying, then you apply primer again, actively 20 seconds, okay, non-touch enamel, then you dry, and then you go with adhesive. So this is a normal way. Maniac way, what does that mean? You do IDS, you use this carbide burr, then you do IDS in dentin, so you cover dentin completely in a full protocol. And then afterwards, once everything is finished, you go with burr just to refresh enamel, and then you can etch enamel and you can prepare your enamel for restoration. This maniac way, I think, is more applicable in case when you do, for example, direct restorations. If you do IDS for indirect restorations, you can do just in normal way, as it was explained before. But for example, you decide to do it for direct restorations. Or what was interesting in our discussion is when you do endodontic treatment, you can do IDS before doing endodontic treatment actually. Okay, so you cover dentin in this way. With adhesive, then you do root canal treatment, and then you go with the rest of the treatment, which is interesting. I never tried it, by the way, but it sounds interesting. Okay, so self etch we covered. Impression taking. What kind of tips we have for impression taking? First of all, we have to understand that oxygen inhibited layer is not a good thing for impression materials. Some impression materials may not polymerize properly in presence with oxygen inhibited layer. That's why we actually use this glycerin gel for light curing and to light cure, to polymerize this oxygen inhibited layer. I would like to remind you, how do we do this? We light cure our adhesive for 20 seconds, then we apply glycerin gel, and then we light cure it again. Okay, so in this way, still you may have this oxygen inhibited layer, because it depends on type of adhesive system that you are using, and all different adhesive systems, they have different thickness of the oxygen inhibited layer. So you have two more options to remove this oxygen inhibited layer. First option is ethanol, so you can take ethanol, cotton pellet, and wipe it out, or you can use, as Pascal Manier advises, is to use paste, pumice paste, and brush. So you will just make a scrub, and there will be no oxygen inhibited layer, so you can take your impression later on. Provisional restorations. This is super important, because sometimes you may have a big problems with provisional restorations, because your material, like for example bisacryl, can be bonded to the IDS area completely, even if you don't have this oxygen inhibited layer. The reason why you can bond your provisional restoration to the IDS is because active monomer that is presented in the IDS area. So if you do retentive preparations, like for example classic crowns or overlays with retentive forms, in this case, before doing provisionals, we can use a thin layer of glycerin gel. Okay, we put a thin layer of the glycerin gel all over all over teeth. Then I take my silicone impression, silicone index. I fill it with a Pro-Temp, for example. Then I go and I can take everything out, clean, and then I use a temporary cement to cement my provisional restorations, which is not that difficult. But when you have non-retentive shapes, which means you have to bond partially your provisional restoration to the tooth in order to keep it stay. So you have few options in such a case. For example, you do tabletop preparations, okay? You have occlusal veneer, there is a dentin exposed, you made IDS, then you take Vaseline, okay? And you cover occlusal surface, which is dentin now, with peripheral enamel, for example. You cover it with a Vaseline, but you keep just one circle, one spot uncovered with, there is no Vaseline in the center, for example. And then you do your provisional restoration. So this spot that was not covered will be as the spot bonded area for your provisional restoration. Considering frontal teeth, in this case what I prefer to do is I do, if I have enamel for sure, I will do line etching of enamel, okay? Then I rinse, I dry. Then I put a really thin layer of bonding to the etched area. I do not light dry it, I just light cured. And then I cover IDS with a thin layer of Vaseline and I keep it. And then I do my provisional restoration. So my provisional restorations will be partially bonded to enamel, and they will be not bonded to this dentin area that is IDS already, okay? Why I prefer this way for anterior teeth when I have enamel is that when I will remove provisionals, when I actually we break them, it's easier then to remove excess of provisional material that is partially bonded to this line edge with, you can do it with a carbide multibladed burr, for example, as orthodontists use for after braces removal. Okay, before I will continue and before I will give you tips about bonding when you cement your indirect restoration, I would like you to see and to watch a very nice video. Hi guys, this video is about benefits that you will have from our online workshop. First, presence effect. This is a unique feature by Belgrade Academy that literally moves you to our training center and you can stay close to speaker. This is like over-shoulder format. The training process is filmed through the video system from the microscope, and there are two more cameras broadcasting close-up and general view. This way you can see everything in precise details. This implies the second benefit, efficiency. Do you agree, guys, that over-shoulder workshop with detailed video and explanation is way better than regular slides and presentation? The third benefit is convenience. So basically you don't need to go anywhere and you can study in comfort conditions, in your home, in your office, during running exercises, from your phone, from your computer, from your tablet, and you can do anything you want with the content. So join us as we shifted online education into the next level. So, bonding day. Now you are ready to bond your final restorations, and now you have to understand how to prepare this area of IDS for that bonding. The good thing is that Pascal and his colleagues, they made a research and they found that OptiBond FL has just about 50% of conversion, which means the rest of 50% of monomers are ready for chemical adhesion for monomers with monomers in your resin cement, which is good, okay? So how do we actually work? We remove provisionals, then we refresh this area, and one of the best way to do it is to utilize air abrasion. So you use sandblasting machine with aluminum oxide, 23-27 microns, or 50 microns, just about 2-3 seconds, okay? And then you go. But some people, they say, after sandblasting, you can re-expose dentin again. It's truth. You can re-expose dentin again. Even you can re-expose pulp if you will work with a sandblaster too long. But if your IDS is thick, as it should be, the risk of re-exposure of the dentin is really low, okay? Really super low. But still there is a risk. So let's make it practical. The IDS has to be thick, and in this case the risk to re-expose dentin again is really low, but it's still possibility to re-expose it. So what we do after sandblasting, we go for full bonding protocol of the tooth surface structures. We etch enamel. Enamel has to be clean. Enamel has not to be with IDS. Enamel has to be enamel. So we do etching for enamel 30 seconds, okay? And then we etch this IDS area just 5 seconds, 5-10 seconds, just to clean it, Then we rinse and then we dry, okay? Since we think or we expect that we may re-expose dentin again, which is rare cases if you do IDS correctly, but still, we apply primer, okay? We talk about OptiBond FL. We apply primer. And then we, on that IDS area, we don't need to apply primer to enamel. Then we dry it, and then you use your adhesive to enamel and to this IDS area, and you are okay. If you use self-etch, so in this case you still have to etch enamel, okay, for 30 seconds, then you rinse, then you dry, and then if you use two-bottle system, like Clearfield SE Bond, for example, you apply primer on this IDS area, just theoretically because you may expose dentin. If, let's say, the situation is ideal, no dentin is exposed, okay? In this case, you skip primer. So you go just for enamel etching, then you rinse, then you dry, then you use your second bottle, you use your bonding agent, you make it thin, then you take your veneer or crown or whatever with a resin cement, you bring them together, and then you light cure, and you are perfect, and you are done, okay? So that was that were highlights from IDS procedure that we discussed with Pascal Magnier. There are many, by the way, there are many studies, there are many articles that are not done by Pascal Magnier and his colleagues, his partners. There are many different articles that prove that with IDS you may have better bonding strength of your indirect restorations, which is really good, and now we can have less postoperative sensitivity, better bonding strength, less aggressive preparations, more comfort, and stress-free dentistry when we work with vital teeth. I would suggest you to read original article that you may find in the Journal of Aesthetic and Restorative Dentistry from 2005. I would like to wish you all the best, all success, and hope to see you during our online masterclass about veneers and color change, where we will be more than happy to show you in details clinical steps of IDS and many other important things. Stay in touch, and bye-bye.